Assalamu alaikum, it's me Dr. Naseem Shahzad, and today I'm going to discuss with you all renal trauma. So renal trauma occur in 5% and less than 5% of all cases of a major trauma, and much of the renal trauma are because of the blunt trauma, and the blunt trauma injury include the fall from height or sporting injury or motor vehicle accident, and the penetrating injury are more common in urban areas, mainly involving this stab wound or gunshot wound to the flank, and are usually more severe than the blunt injury. The most important step in the management of renal trauma is to first see if the patient is hemodynamically stable or unstable. But the first step is the ATLS protocol for any type of trauma, and that involved the primary survey, which include A, B, C, and D, and the secondary survey, in which you will take a proper history and investigation of the patient. If your patient is hemodynamically stable after ATLS protocol, take a proper history, and that should be focus on the relevant factor like the mechanism and time of the injury, any blood in the urine, previous urological history, or relevant medical history to include anticoagulation status and pre-existing renal disease. The previous urological history will tell you is there a patient having some stone disease or decrease in renal function or having history of nephrectomy, and the history of anticoagulant that can help you in diagnose is the cause of hematuria, in this case because of this anticoagulant or the trauma. So after the ATLS protocol, now the most important thing is to go for CT or not. If your patient is hemodynamically stable, the indication for CT in hemodynamical patient and renal trauma as per UA guideline include the penetrating trauma, rapid deceleration injury or significant mechanism, or the systolic BP less than 90 mm of HG at any time, or associated visible hematuria, or they are associated in non-visible or visible hematuria in children. So in these conditions, it's important to go for CT even in hemodynamically stable patient. And the CT, much of the time we are go for CT triphasic or trauma CT, and trauma CT specifically we are going for non-contrast CT head and C spine, followed by the CT triphasic. On the basis of this grading, on this CT we will grade the patient and then will treat accordingly. But if your patient is hemodynamically unstable, so there is no need of CT, but shift the patient direct to theater. Now in hemodynamically stable patient, you have performed the CT, and now the grade the injury. So grade 1 involve the contusion or non-expanding subcapsular hematoma, but there is no laceration. And grade 2, there is non-expanding perirenal hematoma, and there is a cortical laceration which is less than 1 centimeter deep without urinary extravasation. And grade 3, the cortical laceration which is more than 1 centimeter deep without urinary extravasation. And grade 4, the laceration extending into collecting system. And while the vascular injury in grade 4 includes segmental renal artery vein injury with contained hematoma or partial vessel laceration or vessel thrombus. And grade 5 include laceration in the form of shattered kidney, while the vascular injury involved the renal pedicle avulsion. So on the basis of this grading, we will manage the patient. The non-operative management has become the treatment of choice for most of the renal injury, as it is associated with lower nephrectomy rate and no adverse impact on long-term morbidity. So if a patient with grade 1 and 2 injury, treat them conservative. Most of the grade 3 injury is also treated conservatively. But if we treat the patient on conservative management, the complication which can occur in early and late phase include: in early phase, the patient can develop secondary hemorrhage, urinoma formation, infection, abscess formation, AV fistula, or pseudoaneurysm formation. And late complication of the conservative management include hypertension and fibrosis leading to patch kidney, renal insufficiency, chronic pyelonephritis, renal artery thrombosis. But in case of high grade injury like grade 5 and grade 4, these can be managed non-operatively if a patient is hemodynamically stable. Any uncontrolled bleeding will require surgical exploration. Uh, so, what to do with urinary extravasation in case of renal injury? 90% of these urinary extravasation will heal spontaneously and don't require any surgical exploration. Just a drain can help. Monitor the patient for fever or persisting pain, and for significant extravasation, consider placing a ureteric stent. Now coming to the hemodynamically unstable patient or hemodynamically stable patient but want the exploration. So the indication for emergency laparotomy for blunt and penetrating renal trauma include if there is a persisting blood loss causing hypovolemic shock, or there is a renal pedicle avulsion, means grade 5 vascular injury, but not grade 5 parenchymal injury, who are hemodynamically stable. So grade 5 vascular injury need ultimate exploration, but grade 5 parenchymal injury who are hemodynamically stable, there is no need for urgent exploration. And if you have been called during exploratory laparotomy to assess the renal injury, then look for the expanding or pulsatile retroperitoneal hematoma, and look for urinary extravasation associated bowel injury. Bowel may be mixed with urine as a strong risk factor for developing overwhelming sepsis. If the patient clinical condition has been critical such that it has not been possible to arrange CT on the table, so better to go for a single shot of IA intravenous pyelogram 2 ml per kg contrast. That will allow the assessment of two functional kidney extravasation and delay portable X-ray. If normal, may avoid need for kidney exploration. So the purpose of this single shot IVP is to at least make sure that the other kidney is normal if you are going to going for nephrectomy of the injured kidney. And the surgical exploration for these patients include a long midline laparotomy incision from the sternum to the pubis, small bowel gently retracted to away to expose the retroperitoneum. Then we will incise over the aorta above the inferior mesenteric artery. Then we will perform a superior dissection to locate the renal artery and vein which can be ligated. And then we will reflect the colon to expose the kidney. If at a time of exploration the hematoma is found to be non-expanding and non-pulsatile, most can be left alone, as kidney exploration increases the chance of resulting nephrectomy. And how to follow up these patients? The risk of complication in conservatively treat patient increase with injury grade. The higher the grade, the greater will be the complication rate. Repeat CT 2 to 4 days after grade 3 or 5 injury, particularly if worsening plunk pain, onset of fever, or falling of hemoglobin. Declining in long-term renal function correlate with grade. DMSA can evaluate further. And long-term follow-up include BP measurement, urine analysis to look for any proteinuria and urea and electrolytes level.